Good morning, everyone, and again, apology. We'll probably get into the groove of the grand rounds, hopefully in the next few rounds. But some again delays this morning. My apologies. I think we will start as people walk into the Zoom call. Our speaker today is Dr. Flavia Borges. Dr. Borges is an assistant professor in medicine and the division of Perioperative Care Division at the McMaster University. She's an internist at both the Hamilton General and the Juravinski, and an investigator at the Population Health Research Institute. She undertook her master's in health sciences and PhD in cardiovascular sciences in Brazil. And she is focused her research and clinical perioperative vascular fellowship under the direction of Dr. PJ Devereaux. And her research is focused on perioperative cardiac markers, perioperative strategies, and improved cardiovascular outcome in non-cardiac surgery. And she is probably known to many of us leading the HIP-ATTACK trial, and she's going to be talking to us today about that. As usual, we don't have the chat function on this webinar, but you have a Q&A, so please, put in your questions there, and I'll moderate at the end. And if you need to come into the webinar, please raise your hand and you can speak up at that point. So without further ado, Flavia, please go ahead.
Hi, everyone. Good morning. Thanks, Khalid, for your kind introduction. It's my pleasure to be here and to present to you the new paradigm in hip fractures management. I'm going to be talking about the HIP-ATTACK trials. And I'm going to start with a large story that I'm hoping it's fascinating for you as much as it is for me. So in terms of the goals of this presentation, I'm going to briefly review a hip fracture case. Then I'm hoping to gain some insights into the HIP-ATTACK 1 results and implications for clinical care, to learn about the HIP-ATTACK 2 trial, and discuss approach to patients with hip fractures and acute preoperative myocardial injuries. So this story starts several years ago when Dr. Devereaux had a consult in the emergency room for a patient that had troponin elevation. And this patient was having a hip fracture. She was a 73-year-old female, and the referring physician indicated the patient's heart issue, and he indicated that she had to be treated for the heart before he could fix the hip. So the patient measured a series of troponins. She did an ECG. There was some ST depressions. She was moved to CCU. She received lots of fluid because she was with blood pressure a little bit soft. She ended up being on a little bit of heart failure. And there was made a decision to take her to the cardiac lab. She went to the cardiac cath. She had a PCI. She had a stent in. She started on doing antiplatelet therapy, anticoagulation, and she started having a lot of bleeding, and she ended up passing away. So despite the best of intentions, with the standard of care management of fixing the heart first, the patient died before she was able to have the surgery. We therefore question ourselves whether patients may have better outcomes with the opposite management to perform accelerated surgery for those patients. And I'm going to go through the reasoning for this alternative. Millions of adults suffer a hip fracture annually. 35,000 Canadians per year. And here in HHS, we have at the Juravinski Hospital around 240 hip fractures per year. So more than one fracture every other day. And same numbers for St. Joe, so around 240 hip fractures yearly. So we get a lot involved in the care of these patients. Mortality is around 5% for women and 9% for men within 30 days. And we know that these patients, they are old, they are frail, they have multiple comorbidities and polypharmacy. And medicine usually is involved either in the preoperative medical clearance as well as in the postoperative treatment of the common clinical complications. This is an interesting study that Dr. Yannick Lemenac performed with Dr. Devereaux and several investigators from McMaster. They published in JAMA several years ago, and it's a it's a heterospective cohort based on administrative data of 700,000 patients, and they look into more than 800 centers in France, and they compare the outcomes in patients with hip fractures with patients with elective total hip replacement. Because there is a thought that hip fracture patients, they don't do well because they are old, they have multiple comorbidities. But in fact, in this study, they matched the patients for age, for sex, and for comorbidities. So if you can see here in the screen, although patients were matched and they managed to match about 200,000 patients, the hip fracture patients, they have higher in-hospital mortality and higher rates of postoperative complications, such as myocardial infarction, heart failure, stroke, renal failure, sepsis, ICU admission, and readmission after discharge. So there's something about the hip fracture per se that is causing those complications. The conclusion was that those patients undergoing hip fracture surgery, they have higher risk-adjusted mortality than those patients undergoing elective total hip replacement surgery. So when we think about risk factors to have mortality elevated after a hip fracture, there are several risk scores. We know that sometimes in medicine, we are used to do the RCRI, the Revised Cardiac Risk Index score. And this is a score that's more useful for elective surgeries. So I see a lot the residents in the preoperative assessment in the emergency room doing RCRI for hip fractures. It is important. It can acknowledge cardiovascular complications. So we go through history of coronary artery disease, heart failure, diabetes on insulin, kidney disease, and those scores give you points to have a prognosis. However, in hip fractures, this is a different population. This score, called the Nottingham Hip Fracture Score, was performed in UK in about 5,000 patients. It was a prospective cohort, and they looking specifically in hip fracture. What are the risk factors to have higher mortality at 30 days? And you can see here in the score that age counts a lot. That's not in the RCRI. You may have 4 points if you are older than 86 years old. Male gender, hemoglobin on admission, less than 10. Patients with previous cognitive impairment, and here in the score, they use the mini mental test score. Patients coming from institution, patients with 2 or more comorbidities, and patients with a history of malignancy. So the more points you get, the higher your mortality at 30 days. The original score was overestimating the complications. However, they did validate in further cohorts in UK, now doing in several different centers across UK and Europe, but still the score is very valid for this population. So when we look into those risk factors, if we think about age, male gender, socioeconomic deprivation, comorbidity conditions, dementia, and nursing home residency, most of them we cannot modify. And there are several other studies pointing out that surgical delay is a very important risk factor for mortality. And certainly as physicians and as healthcare workers, we can work to tackle the surgical delay. So based on that case, Dr. Devereaux, together with Dr. Mohit Bhandari, decided to perform a systematic review to look into the surgical delay as a factor for higher mortality. They performed a systematic review and meta-analysis, looking into patients with hip fractures, and they could screen about 2,000 papers. Only 16 were included in the review. And what called the attention is that there were no randomized controlled trials on this topic. So they performed the meta-analysis based on observational studies only. And only 5 of those 16 studies, they had multivariable adjustment. So we are talking here about 4,000 patients, 700 deaths. And in the systematic review, early surgery was associated with lower mortality. So mortality relative risk was 0.81. So maybe 29% relative risk reduction for mortality. However, we know that those studies had some frailties because they were observational studies, and also because early surgery definition vary a lot across the studies. So some of them defined early surgery as less than 72 or 48 or 24 hours. It was then decided to perform a randomized clinical trial to look into early surgery compared to standard of care to inform on the mortality benefit that was suggested by the systematic review. There was a lot of debate if it was possible to perform really early surgery, and then a HIP-TECH feasibility pilot was performed here in Hamilton across the 3 sites with 60 patients, just to try to prove it was feasible, and it was successful. So in the pilot trial, we managed to achieve the goal of 6 hours from orthodiagnosis to surgery in the accelerated care group, comparing with the standard of care. That is usually 24-48 hours that complies with the Ontario benchmark to perform a hip fracture surgery. These are the results of the HIP-TECH 1 trial that we published in the Lancet last year. We performed a randomized control trial to determine whether accelerated surgery for hip fracture was superior to standard of care in reducing death or major complications, including older patients with frailty hip fractures that require surgery. The intervention was the accelerated surgery with the goal of performing surgery within 6 hours of the hip fracture diagnosis compared to standard of care. And our co-primary outcomes at 90 days follow-up were all-cause mortality and major perioperative complications. So relevant complications such as myocardial infarction, venous thromboembolism, pneumonia, sepsis, stroke, and major and life-threatening bleeding. We randomized almost 3,000 patients across 69 centers in 17 countries, and we achieved greater than 99% follow-up at 90 days. These are the baseline characteristics. So you're going to see that the population is very similar to what we see in our clinical practice. So patients around 80 years old, most of them are women, and they have lots of comorbidities. 2/3 have hypertension, 1/3 need assistance with activities of daily living, 1 in 5 had diabetes, 18% were coming from a nursing home, and 17% were having dementia. This is only to take a look at the type of anesthesia. So usually it reflects the clinical practice where most of those patients perform spinal anesthesia, just 1/3 had general anesthesia, and the different types of fractures. So the most common fracture is intertrochanteric fracture, followed by femoral neck fracture. And the most common type of surgery is open reduction and internal fixation. There was no difference across both groups. This is in regards to our intervention. So you're going to see in this table that accelerated median time for surgery was 6 hours in the accelerated care group compared to average 24 hours in the standard care group. So there was a good separation between the two groups of at least 18 hours. The primary outcomes at 90 days were no different between accelerated surgery and the standard of care. You're going to see here that for mortality, the hazard ratio was 0.91, p-value 0.40, and the composite of major complications was also no different, hazard ratio 0.97 and p-value 0.71. This is a busy slide with lots of numbers, but I want to point it out that when we look into individual clinical complications, including cardiovascular complications and bleeding, there was no difference between the two groups. However, it's important for us to see that in hip fractures, the mortality is split half and half between vascular and non-vascular mortality. And it's also important to flag, because this is one of the outcomes that we need to change, that myocardial infarction is common, 6% of the cases, heart failures happen in 2%, clinical important atrial fibrillation in 2%, compared to venous events that are rare, 1% of venous thromboembolism. So when we see hip fracture patients, we tend a lot to think about pulmonary embolism or DVT, while in fact, most patients, if they have a complication, they will have arterial as opposed to venous complications. So we have to focus in myocardial infarction, heart failure, and new clinically important atrial fibrillation. Most likely, we are already applying great prophylaxis for VTE and also encouraging early mobilization. So we now have to move on to improve vascular arterial outcomes. Here are some secondary outcomes that are important, and our intervention had some benefit. So if you see in this table, patients that had infection without sepsis, they had 11% of those complications in the accelerated care group, 14% in the standard care group, has a ratio 0.80, so 20% relative risk reduction in infection without sepsis. For sepsis, there was no difference, but again, 5% of those patients are having sepsis within 90 days across both groups. Accelerated surgery was associated with some improvement in terms of stroke, however, very few events, so we offer caution in the interpretation of this result. Importantly, delirium happened in 132 patients in the accelerated care group, 175 in the standard care group, with a hazard ratio of 0.72. This was statistically significant. And for us clinicians that we are called to the ward to see hip fracture patients in delirium, we know that this is a very important outcome in terms of prognosis and also in terms of patients and caregivers, important outcomes. When we look into the type of infection, the benefit was driven by urinary tract infection. Most likely, those patients, they stay on the ward with a Foley in up until they do the surgery. And as soon as they perform their surgery, we remove the Foley. So the faster you do the surgery, the benefit in terms of removing the Foley and reducing urinary tract infections. In terms of mobility outcomes, accelerated surgery was associated with improvement in early mobilization, standing, full weight bearing in comparison to standard of care. The absolute difference vary about 21 and 26 hours earlier for accelerated surgery. And also, accelerated surgery was associated with a short length of hospital stay. And this can have impact in terms of costs. And we're proceeding with a cost-effectiveness study to look into this issue. Accelerated surgery was also beneficial in terms of reducing moderate to severe pain scores compared to standard of care, post-randomization days 4 to 7. And this is a subgroup analysis that we did based on the index case that motivated the trial. So I told you about that case that had a hip fracture and troponin elevation. So here, when we look into this forest plot, you can see that across the overall population of hip fractures, our intervention was no different between accelerated versus standard of care. However, when we split this population in patients that had troponin elevation with patients with no troponin elevation on emergency room arrival, then we see a different result. So first of all, you can see in this figure that patients that have troponin elevation, they had 24% mortality in the standard care group at 90 days, compared to 8% mortality in patients with no troponin elevation. So there is no debate. This is a very high risk group. The question is that if we can modify this risk, and when we look into our intervention, patients that had troponin elevation that underwent accelerated surgery, they had 10% mortality compared to 24% mortality in the standard care group, with a hazard ratio of 0.38, and the p-value for interaction was statistically significant. We look into the same analysis, but now with the primary composite of 90-day major complications. And the results were again favoring accelerated surgery. Patients that had troponin elevation that underwent accelerated surgery had 21% major complications at 90 days, compared to 34% in the standard care group, with the hazard ratio in the direction of benefit. However, this was a subgroup analysis that was done post hoc, so we need to move further with our research to confirm those findings. The takeaway messages from HIP Attack 1 are that among patients with hip fracture, accelerated surgery did not significantly lower the composite of major complications or mortality. However, there was no evidence of harm with accelerated surgery, even when we look into the subgroups with acute medical complications. And accelerated surgery demonstrated lower risk of delirium, urinary tract infection, pain. It was associated with faster mobilization, standing, full weight bearing, and also shorter length of hospital stay. Accelerated surgery demonstrated mortality advantage in patients with elevated troponin before randomization. We therefore start to question ourselves if hip fractures could be potential medical emergencies. So if we compare with other acute conditions, such as myocardial infarction and stroke that have poor outcomes, and they are improved by the rapid treatment, we could think the same about hip fractures. However, based on HIP Attack 1, I don't think this applies to all hip fractures population. We have to identify who are the patients sitting in the emergency room that would most benefit from accelerated surgery. So if we look into that subgroup with troponin elevation, we see that acute myocardial injury in hip fractures, they happen in 1 in 4 patients that have hip fractures. So it's very common. 25% of patients coming in the emergency room have an elevated troponin. These patients, they have 3 times higher mortality. They are often asymptomatic. So if we do not measure the troponins when they are coming in, we are not going to identify this population. And they are characterized by an elevated troponin. There is other research that support our findings. So I'm performing a systematic review. There are very few studies looking into preoperative troponins. They are mostly retrospective studies, but this is one of the best that I could find. This is a 200-patient prospective cohort, and they measure troponin before surgery and post-op day 1 and 2 in hip fracture patients. And they identify troponin elevation in a third of those cases. And in this figure, you can see in green that patients with troponin elevation at 30 days, their mortality was 17%, compared to 5% mortality at 30 days for patients with no troponin elevation. And here they add an information that, in fact, the higher the troponin levels, the higher your mortality. And this was an independent factor after multivariable adjustment. One of our co-investigators from HIP Attack 1 and 2, Dr. Gerard Slobodjan from Maryland, decided to look into his hip fracture cases. And he looked into a retrospective cohort of 300 patients that had troponin measured when they came into emergency room. 14% of those cases had troponin elevation. Only 3 out of 43 patients underwent a preoperative PCI. And when he looked into timelines for surgery, definitely those patients are having more delay. So patients with troponin elevation, they wait 42 hours to perform surgery compared to 21 hours in patients with no elevation. And they had higher 90-day mortality. Their mortality was 30% compared to 18% in the patients with no elevation. And finally, this is another study that look into long-term prognosis. So it seems that it's not just at 30 or 90 days. This study looked into 1 year across 108 patients. 1/3 of those patients had troponin elevation on hospital arrival, and mortality was different in patients with troponin elevation and with no troponin elevation at 1 year, 45% compared to 22%. This is some preliminary data from HIPATEC-1 trial. This is still to be published, but I want to show you because these are very interesting results. A common question is that, wow, if you have a very high troponin level, are you sure it's safe to perform accelerated surgery? We are still to answer this question. However, what we see here that makes sense is that the higher the troponin level, the higher the mortality. So here is troponin tertiles. You're going to see that patients with no elevation, they had around 9% mortality, but the higher the tertiles of troponin, your mortality in the higher tertiles can be as high as 30% at 90 days. And it's interesting because when we split our HIPATEC population across those tertiles, you can see here that I'm looking into groups with higher biomarkers in this direction. And you're going to see here the hazard ratio. So it seems that the higher the troponin, the higher the benefit of performing accelerated surgery. The hazard ratio in the higher group of patients with troponin elevation greater than 2.5 times of the upper limit was 0.17. However, the p-value for interaction was not different across this subgroup, and it's because we are underpowered and we need a larger trial to confirm these findings. So definitely, hip fracture has acute consequences. Hip fracture is a trauma that causes immobilization, pain, and bleeding that can trigger inflammation, hypercoagulability, catabolism, and stress state. And all of this together can cause clinical complications. And we see patients having pneumonia, thromboembolism, stroke, but importantly, as I show you, a common complication is myocardial injury and myocardial infarction. In fact, in HIPATEC, postoperative myocardial injury happened in 1/3 of those patients. And all those factors together, they can drive patients to have a higher mortality in the coming months. When we talk about myocardial injury, I just want to point it out that this is a spectrum. So this is a figure from the 4th definition of MI that included myocardial injury definition. The criteria for myocardial injury is a detection of an elevated troponin, any value above the 99th percentile of the upper reference limit is defined as a myocardial injury. And it is considered acute if you have a pattern of rise and fall. And here you can see that all those patients in orange, they have myocardial injury identified by troponin elevation. And in the core, you will have a proportion of those patients that are actually having myocardial infarction. Myocardial infarction here is defined by the troponin elevation plus an ischemic picture. So those patients with MI, they have to have either symptoms, but our patients, they are having pain for their hips. So they arrive in the emergency room, they receive opioids, and they don't have chest pain at all. So it's very hard to identify patients suffering myocardial infarction in this context. And also they could have some ECG changes. So there's a lot of factors that play a role in triggering a myocardial injury. As you can see here, you can have hypoxia or anemia or any arrhythmia or hypotension or some kidney disease, either chronic or AKI or symptoms of heart failure. And all of this can trigger myocardial injury and myocardial infarction. If we look into this figure, this is about myocardial infarction, but as I said, myocardial infarction is a spectrum of myocardial injury. So in one hand, you can have what you usually think about a thrombotic type 1 event. And this is usually triggered by the context of hypercoagulability, inflammation, endothelial dysfunction, platelet activation, and thrombus formation that actually happen in the context of the hip fracture. But also you can have a type 2 event where we are talking about supply and demand mismatch. And this is usually caused by sympathetic nervous system activation, hypercatabolism, tachycardia, bleeding, hypertension or hypotension, and hypoxia. We have data from the perioperative MI that most cases are actually more supply-demand mismatch. So Dr. Teshet from McMaster, he did a study looking with OCT in the coronary arteries of patients having a perioperative myocardial infarction. And in the context of periop, about 87% of the cases are not thrombus. They are supply-demand mismatch. So most likely in hip fractures, we are leading with supply-demand mismatch ischemia. So we think that this elevated troponin at presentation, triggered by all those factors, is actually identify a patient that does not tolerate the stress of the fracture. And it's very possible that accelerated surgery, by reducing the time exposure to those factors, can reduce the physiological stress and then can improve patients' outcomes. Now we face a clinical dilemma. We have a patient with hip fracture and myocardial injury in the preoperative setting. So we as clinicians debate in terms of what should we do for those patients. If we should do further cardiac investigations and cardiac stabilization, but we know that if we wait to do series of troponins and ECG, and if we perform echo, we are gonna be delaying the surgery. Or we could propose the opposite, try to expedite the surgery, fix the trigger for the myocardial injury, and hopefully we're gonna have better outcomes. So this is an analogy with, for example, upper GI bleed. When a patient comes in an emergency room with upper GI bleed with severe anemia, and they have a troponin elevation, we never debate to treat that troponin, to take those patients to cath lab or to start treating as an acute myocardial ischemia. We think that's because of the bleeding. And usually what we do is do blood transfusion, upper scope, and control the bleeding. And we hope that fixing the trigger, we are going to improve the myocardial ischemia. That is a secondary event. So here would be the same reasoning. And when we look into the advice from the guidelines, here you can see the guidelines from the CCS Society. You see that hip fractures, they are usually urgent semi-emergency surgeries. So the recommendations from the society are to proceed to surgery and only undertake preoperative cardiac assessment if a patient has an unstable cardiac condition. And we could fit myocardial injury under unstable cardiac condition. But then the recommendation is to discuss with the patient, the surgical medical team, whether we should delay surgery versus proceed with the surgery and weigh the risks and benefits. So this is what we do in our everyday clinical practice. However, this is based on expert opinion, and we would need to advance further evidence. The idea of hip attack 2 is that patients with hip fracture and the baseline elevated troponin, they will benefit from accelerated surgery by reducing the time exposure to that physiological stress associated with the hip fracture. We plan to perform a randomized control trial in 1,100 patients, including the same patients as of hip attack 1, same profile of patients. However, here we are selecting only patients that have troponin elevation on emergency room arrival. We are going to exclude patients on therapeutic anticoagulation that we cannot reverse. And also in terms of safety, patients with ST elevation MI and cardiogenic shock. When patients come into the emergency room with hip fractures, we are going to be proposing to screen troponin for all those patients to identify high-risk patients. then assess for eligibility and perform the orthopedic diagnosis, and then randomize a patient either to the accelerated care surgery, trying to do a rapid medical clearance and OR access within 6 hours from the ortho diagnosis, compared with the usual care, that is to book a hip fracture surgery around 24 or 48 hours. And we're going to follow all patients for our primary outcome, that is 90-day all-cause mortality. Of course, we're going to look into some secondary outcomes, including functional outcomes, individual cardiovascular outcomes, delirium, pain, and quality of life. We have 51 confirmed sites for HIPATEC 2 across 16 countries. Most sites are coming from North America and Europe. And we have the goal to activate our first site that we hope it's going to be the Juravinski Hospital in the next couple of weeks. And just to finalize, I think that this theory does not apply only for hip fractures. Actually, I think that any patient coming in with an acute surgical condition that can be triggering all that cascade could benefit from accelerated surgery. So we are performing a pilot trial called the FAST trial. It's happening here across the 3 Hamilton sites, and we are looking into a different population. Here we are looking into acute cholecystitis, but with the same reasoning, randomizing those patients to accelerated care versus the standard of care, and we are assessing feasibility of performing a large clinical trial in this population. So in conclusion, preoperative myocardial injury in hip fractures is associated with poor prognosis. Mortality is 24% at 90 days. The best medical management is still unclear. There is this balance of the surgical delay versus increasing bleeding and also hypotension. The best timing for surgery is not known. HIPATEC 1 suggests that we may have some mortality advantage with accelerated surgery, and we hope that HIPATEC 2 will answer this important question. So we would appreciate your help in undertaking this trial. And in terms of clinical implications, so far, the hip fracture guidelines recommend that surgery still should be facilitated within 24 or 48 hours, and logistics and resources required for accelerated surgery will need to be balanced with the demonstrated benefits and patients' desire for accelerated surgery. So I'll leave my contacts here if you want to contact me about any questions later on, and also our team of HIPATEC. But I'm very open for discussion now, and I want to hear your thoughts. Thank you so much.
Flavia, thank you so much for taking us through this. This is an important area that you're researching, and new science that's developing, thinking about how myocardial injury should accelerate surgery. So it's very intriguing. If you have any question, please put your questions in the Q&A section, or if you would like to speak up your question, don't hesitate to raise your hand and I'll bring you into the panel. So there is a question from Dr. Satya around the cost of quality life year using the accelerated approach and whether that's been looked at.
Well, important question. I think it's a core question, actually. We still don't have the results, but we are performing a cost-effective study, and we did collect in HIPATEC 1 quality of life measurements, and we are hoping to have this publication soon. We are going to do this analysis for Canadian sites. So we're next presentation, maybe I'll bring up the results.
Fantastic. I think the second question or comment is actually answered by your HIPATEC 2 trial. So great. There's a question from Dr. Preptani around statin use in this situation with mins and pre-op, the effect on that.
We don't know. I think this is a very interesting area because when you look into the evidence, we advance a lot in the mins area. So in the myocardial injury after non-cardiac surgery, we have observational evidence that statins may improve those outcomes. And actually in clinical practice, because we don't have any RCT we do prescribe statins for this population moving forward. We have some evidence that those patients actually, majority of them, they have underlying CAD, that it's stable, and with the insult of surgery, then we trigger troponin elevation, and likely they will benefit from this secondary cardiovascular prevention medications. So now we have to extrapolate to preoperative myocardial injury, causing not by the surgery per se, but by the acute hip fracture. So we still don't know. We certainly are going to collect that data. So we are going to look into when patients come in, if in the standard of care, they are started on statins, on aspirin, etc. We're going to look into all the outcomes. So I think we're going to have some, although it's not going to be an RCT, we're going to have some evidence in that direction.
Great. I have a question. I mean, I'm listening to your presentations. Actually, just it's for someone who's practiced for so long, it's really becoming difficult to balance the odds. So you're taking someone who is someone is undergoing a strain that is causing type 2 myocardial injury, and potentially putting them on to additional strain, which is a quick surgery that could cause further injury without any further interventions. And we're getting potential an observational trial now, hopefully in your HEPATAC 2 also further evidence that actually is going to be beneficial. So physiologically, how do you balance those odds, that, well, we are causing more stress?
Yeah, well, I think this is the usual reasoning, and this is why we usually delay surgery a little bit. We trend the troponins, we wait the troponins to come down, and then we feel more assured that this patient can proceed to surgery. Looking into the data we have, I have the feeling we are not doing the right thing, because those patients that are waiting for surgery, they are dying. 1 in 4 is dying in 90 days. So I think it's a time for us to test the other hypothesis. I know that we're causing more stress with the surgery, but actually we don't know if the stress of the surgery is higher than the burden of the hip fracture. It seems that it's not. And when we look into individual patients in HEPATAC 1, we saw a lot of patients that had troponins higher than 1,000. And when they did surgery, actually the troponin trend down, suggesting that we were removing the stress. So I think we just could reach that concept because we had the preoperative and the postoperative troponin. So we were looking into the trend, and actually it seems that the troponins trend down after surgery as opposed to increase. And when we did an analysis in HEPATAC 1 also, because I was wondering to look if into patients that we did accelerated surgery, we were causing more postoperative MIs. And it's a small population, so we don't have major conclusions, but the data that is still preliminary points out that actually we're decreasing MIs as opposed to increase MIs after accelerated surgery when we compare to standard of care.
It's very intriguing, and I'm really excited to get to know what the results may come out of the HEPATAC. So we all have to. All of us who come across these cases should help in recruiting patients into this route. Dr. Kerner is asking about, who should be turned down for hip surgeries, listing at advanced dementia, bedridden, and frail patients, So is that part of what you're looking at, or is actually all comers as long as they don't have a complicated myocardial injury?
Yeah, this is an important point. So it's very rare that we decline hip fracture surgery for patients because they have a lot of pain, and we are saying basically that they're going to stay bedridden. So for patients that have severe advanced dementia at baseline, plus they are bedridden, sometimes we decline, but we know that the prognosis for those patients is very poor. They have a very, very high mortality. So because the surgery is not that complex, sometimes we perform surgery just to control the pain for those patients. And there's a lot of benefit because then they don't need a lot of opioids and the quality of life improves. So it's a balance. But to reply to the question, we are not including patients that are not eligible for surgery. So usually the first inclusion criteria is patients that ortho assess and there was made a decision to perform surgery. When we have a decision to perform surgery, then they are randomized to accelerated versus standard. But I would say that from what we look in HIPAA 1 screening data, I would say I think 1 or 2% of patients are declined surgery due to bad dementia and being bedridden.
Okay, I want to thank Dr. Patel for putting a comment in the Q&A about how we should be managing or addressing the precipitant, something that Flavia did address during the presentation, managing the precipitant to prevent further injury. So thank you very, very much. I think there is now Dr. Devereaux, I'll bring you in. Oh, I lost you. I don't know. PJ, if you want to come in, please raise your hand. I think you were on and disappeared. I'm also wondering, as going forward with the hepatitis 2 in terms of if this becomes standards of care, how feasible is getting hip surgery done in 6 hours, not only in our highly trained centers and specialized centers like the Jarvinsky, but across the world?
I didn't mention, but we are testing this intervention during working hours. So I think it works when we have all stakeholders on board. So when we have, ortho is on site and medical clearance team and anesthesia. So basically we are proposing this for working hours. We're not talking about performing surgeries overnight, for example. And we compare with MI again, when they started doing, rapid PCI for ST elevation MI, they started the intervention first during working hours to see if it would work with everybody on board. And now several years later, we know that if you have a STEMI, it doesn't matter what time, you're gonna call the cath lab immediately. So I think this is the first step. We are looking into performing accelerated surgery when you have all the team on board. But that being said, I know that it's complicated to organize the OR flow, but I think we need to understand who are the patients that have mortality benefit in accelerating surgery. So if we prove that we can really decrease mortality, like 50 or 60% for those cases, I think they should be a priority. And as opposed for us to book them as a priority 3, they should at least move to a priority 3.
I think PJ is on. Dr. Devereaux, do you have a comment? Okay, I'm not sure if he's on. Well, that's there's another question from Dr. Satya. I was wondering how you plan to manage antiplatelet therapy versus risk of bleeding during surgery in high-risk patients or high-trop patients, sorry.
Yeah, so we had this issue in HIPAA 1 as well. So we have lots of patients that come in using antiplatelets. I would say aspirin is not a problem. You can proceed for surgery right away. The issue is when you're on dual antiplatelet therapy and then you have aspirin and Plavix, and we know the risk of doing spinal anesthesia and having a spinal hematoma. So for those patients, what we were doing is actually to perform general anesthesia. And we don't have clear evidence that general anesthesia is worse than regional. So we thought it was reasonable, but then we would discuss a case by case with the anesthesiology group.
I think Dr. Carnot has a comment, so I'm just bringing him in.
Can you hear me?
Yep, go ahead.
Now we can, yes.
Yeah, sorry. So sometimes I remember seeing a patient that had ST elevation on their ECG, totally asymptomatic, and I know they got randomized. So I get it if you think the patient has a history of plaque rupture, but many of these patients don't have symptoms or can't give symptoms, but they have a very ischemic looking ECG, either ST depression or ST elevation. Do we approach those patients any differently?
Important question. So we were debating and we decided to ST elevation MI is an exclusion criteria, but because we think these patients are likely having type 1 MI, and then they will fit in a different category that they may be an exception, that they may benefit from delaying surgery. So no ST elevation MI. However, I would say that looking into the literature, we have very few cases because usually we don't do preoperative cardiac cath. but there is one study that among like 1,100 patients with troponin elevation, 5 had ST elevation MI. Those patients were taken to the cath lab, and actually it was Takotsubo. It was not a thrombus. So it's possible that the stress of hip fracture also causes stress cardiomyopathy, and then you have ST elevation MI. But because we don't have confidence, I think this population, we are not going to be studying at this time. However, patients that fit for non-STEMI, if they have some ECG ischemic changes, we're going to look into case by case. But we have the hypothesis that those patients will even benefit more, because we see patients that are having ST depression with troponin elevation. You take them to OR, they get out of the OR, troponin comes down, and ST depression comes up. So those patients, we plan a subgroup analysis actually to looking into them to see if they will have more or less benefit in terms of the intervention.
Excellent. Just actually, Dr. Devereaux just typed a comment. I think he might have a technical problem coming in, and it's about the patients who are nursing home patients with dementia. Surgery does actually improve outcomes in terms of reduced risk of pain, rupture ulcers, and immobility compared to no surgery. All right, fantastic. We are at time. Dr. Borges, this is fabulous. I mean, this is your challenging what conceptions of perioperative medicine is, and you continue with Dr. Devereaux and your group doing that. So thank you very much for creating this new science. And I encourage all people who interact with hip fracture patients to support you in recruiting those patients for these fabulous studies. So thank you very much, and thank you for your great work here at McMaster. For everyone,
wonderful.
Thank you for joining us, and have a great day.
Thanks, Khalid. Thanks so much. Take care.